two.
Good afternoon. A very warm welcome to AMREF International University. Welcome to our audience in the auditorium, and a very warm welcome to our online audience. This is our first COVID-19 public lecture, and we are really honored to have Dr. Gidinju Gitahi, who is the AMREF GCEO, with us. We are also honored to have the AMREF Vice Chancellor, Dr. Professor Osur, with us. We are going to have an interactive session. This was specially designed to reach out to the students in the universities, students in colleges. We want to have a discussion about COVID-19, the past, the present, the future, your experiences, your thoughts, your questions. So this is your session. I want to welcome Prof. Osur to also welcome you, and then after that we can continue. Prof, karibu.
Yeah, thank you very much, and a very good afternoon, colleagues. I know there are a number of people who are logged in online. We have questions from Somalia, from Tanzania, from Uganda, from many parts of Kenya. And so we know a lot of people are watching from within and from outside Kenya. We want to welcome you to this very interesting session about a very current issue which requires our discussion. Let me start by thanking our student leaders and the student community of AMREF International University. In our university, we do what is called student-led learning. This was their idea that we need to come together and discuss this issue. And our students have also been going out to Kibera to mobilize and vaccinate against COVID in the population in Kibera. The difference that we have in our university is that our programs are student-led. And so we will be seeing a lot more of this kind of arrangement where students are inviting lecturers and leaders in health to discuss issues about health. This is especially very important at this time when everyone is talking about competency-based education and training. We want to have our students leave this university ready to do the work. And so this interaction with experts in the field and in the classroom and being hands-on and offering help to communities is something we very much value. And that is why I'm thanking student leaders for taking these initiatives. We, especially in Africa, need to bridge the gap between knowledge and practice. If you are in the health industry or in other industries, you will realize that when you do interviews for people who have graduated from many of our universities, there is always a disconnect between the knowledge that they have and the hands-on experience, to the extent that in Kenya, for example, we now seem to value more mid-level colleges than universities because people think that universities are not offering hands-on experience. And so for us, it is different. And this is why, again, I say thank you to our students for leading this initiative. Our hope is that this leadership that you continue to show right now and in the many other initiatives that you have undertaken will translate into leadership for health in Africa. When you leave this university, from whichever country that you come from, that you will be able to continue showing that leadership and moving things in the health sector for the betterment of our African communities. I want to take this opportunity also to really thank our group CEO, Dr. Githinji Gitahi, who is a champion for transformed health in Africa, for lasting health change in Africa. He has led us through this initiative for the last few years, and I think everyone knows what AMREF stands for because of his being a champion and talking about it so passionately in the many fora that he represents the organization. Today, in his busy schedule, he has created time to be here and to be a guest lecturer in the university. And we thank you for creating time. We are looking forward to a very interesting session. As you know, Dr. Githinji holds many hats. Apart from being the group CEO of AMREF, he's a provider of health services. If you don't know, Dr. Githinji has created time previously to actually be a community health worker. He went to the community and did what community health workers do, interacted with communities, moved from house to house, and offered the services. Because he's a trained doctor, and he keeps talking about community health workers, and he didn't know what it actually feels like. And so he did that. So he has experience from the community level to the health facility level at a very high level as a doctor, because he's worked there. He's also interacted a lot with the private sector, and he knows what private sector can bring to health. He works very closely with governments in Africa, and so he knows what governments can bring. And is presently, as you know, in the Commission for COVID for Africa, set up by Africa CDC. And so he's a leader in the continent on this matter. We welcome you, and please take over. Thank you very much.
Thank you very much.
But I see people want to clap for you, so.
No, I think they're actually clapping for you because they, you know, you clap for the person who's just finished talking, not the one who is starting. Because, you know, if you clap for me ahead of time, I could then disappoint you, isn't it? But thank you very much, Prof. Thank you, Anne. I'm really honored to be here today. I will take the privilege of removing my mask so that we can communicate clearly. And I see we have a lot of people online. We have more than 100 people online, for those of you who can't see them, and then the people in the auditorium here. So I'm really honored to address this August gathering of AMREF International University. If you could give me my slides, I would like to share a few slides. This lecture, I have seen a lot of questions here, by the way. We had questions that were shared. The moderator, Anne, who is the president of the Students' Council here, has shared with me the questions that were sent. I have a set of more than 26 questions that were sent in advance. I hope I can answer as many of them as possible through my presentation. Whichever one I don't, then I will pick it up as we do the panel conversation. And again, as I always say, it's not a preserve of any individual. And therefore, this being a university lecture is a lecture with the, it's not just for me to talk to you, and therefore, any of you can also answer any of the questions that actually appear. It shouldn't just be myself speaking. So I'm hoping that we'll have an engagement. So let's see. Yes, good. Share that. So this conversation, which is a guest lecture invitation, is my thoughts on the past of COVID, the present, and the future. And it is more provocative thoughts rather than an account of the statistical numbers that we have seen. It will be boring 2 years after COVID started for us to go through the trends. It's important only if the trends speak to us. That's the only time we should use the trends rather than use them as the subject of the lecture. So I hope you allow me to do more of the provocative side of what I think and my thoughts for this. So please give me, yes, please go there. And if you could remove the top part, if you're able to, that would be good, because then I can see the entire slide. The pandemic timeline started in December 2019, as you all know, and it started with an unknown virus that emerged in Wuhan, China. And at that point, there was a cluster of unusual severe pneumonia that was seen. Before this, we all knew that there was always the talk around disease X, that something could appear, that there could be a pandemic, there could be an outbreak of something we don't know. And we had outbreaks before. We had an outbreak of Ebola, we had outbreaks of MERS, MERS, we had outbreaks of SARS, and we've had many other outbreaks, including the HIV pandemic, which is still running with us today. People always said there is likely to be disease X, something we don't know that's going to come. And this new disease X could have been either a re-emerging virus or pathogen that we already knew about. It could be a new emerging virus that we didn't know about. So at this point, there were studies of this particular unusual class of severe pneumonia, and finally was classified as a coronavirus. Of course, you know that there are more than 1,000 coronaviruses, so they are everywhere, but they reside largely in animals, but a few of them, about 6 or 7 of them, have crossed over to human beings. And this is one of them. I think this was the 7th to cross over to human beings. And why so? Because of mutations or changes, but also because of interaction between individuals and animals, individuals and the environment. And that interaction then gives the opportunity for a particular pathogen, which is used to being in a different host, to actually change itself and jump over to another host. Because ideally these coronaviruses are hosted in animals, bats, and other animals. So in the crossover, there was investigation, and the international health regulations, any of you who is a student of health systems should pay attention to what we call the international health regulations. The international health regulations is a global compact on how countries and individuals, especially governments themselves, should relate with each other on health security. Because we are an interconnected world, and you could have any of these emerging or re-emerging pathogens coming up in any country in the world, the international health regulations is the guidebook to what countries should do, either to discover a new pathogen that the world doesn't know, that actually becomes a danger to other people in the world. And these international health regulations, which was actually put together in 2005, guides in terms of what should countries do? Should countries report or not report? Should countries inform others or not inform others? And what are the obligations of every country? Okay, so this is really what the international health regulations talk about. And the international regulations are a binding agreement by countries. They're not an option, they are a binding agreement. And they also define how countries and WHO how something like a pandemic should be announced. That's where they are, that process is located in the international health regulations. The process of how do you declare a pandemic? And by pandemic here, we are meaning something that is a threat to multiple countries at the same time. In an outbreak, if you are to think about epidemiology, you'd think about an outbreak as something localized. So when we have a cholera outbreak in any country or any community, that's an outbreak. But as it moves forward, it could actually become an epidemic. And if it's affecting more countries than one, then it could be a pandemic. So the pandemic is declared by WHO through the international health regulations. Secondly, for you to declare a public health emergency of international concern, which is called a FAIC, by the Director General, it is informed again by the IHR. So if you're a student, either in Amref University or any other university, and you're a student of health systems, and health systems is anything that's dealing with the health and management of health, then you should understand the IHR, because that is the global tool of health diplomacy. Now, within this, the WHO established what they call the Emergency Committee. And the Emergency Committee on 31st of January 2020 then advised the Director General to declare a public health emergency of international concern. By that time, Africa had not experienced its first case of COVID-19. Then the first case of COVID-19, was identified in Africa, in Egypt, on a date that I hope none of you would forget. It was on 14th February 2020. What happens on 14th February? It's Valentine's Day. Only the ladies raise their voice. So guys, please lift your, pull up your socks. So on Valentine's Day 2020, the first case was identified in Egypt. And therefore, Africa went into high gear. Already, even before this case came to Africa, many of you will remember, governments had already started putting together response committees, task forces. Parliament had started to, cabinet had started to meet. So Africa was really preparing itself. But you see, you prepare yourself by seeing what's going on in Italy, in Germany, and other places. But, the proof of the pudding is in the eating, isn't it? So whereas these were conversations, they now became real engagements after 14th of February. And any country or anyone of you listening to me here would remember when in your country this thing started. Now, after that, we got WHO now declared it a pandemic. At that point in 14th of February, it wasn't a pandemic. It was just a public health emergency of international concern. It was declared a pandemic around 11th March, and then by then there were already travel restrictions. The IHR also does prescribe when travel restrictions should be done. So it's a really important document. And that's why I'm repeating many times that if you want to understand pandemics and how and the role of communities, the role of government, the role of regional blocks in how to manage a pandemic and how each country should build its own health system to be part of the global management of pandemics. They are what we call core competencies of the IHR. And those core competencies speak to health systems in a country, because pandemics start in a community and end in a community. So in which community did this pandemic start? Which community? It started in a community. In Wuhan, isn't it? It started in a community in Wuhan in China, in a small community that was a market. That's where pandemics start. They don't start in the air. They don't start anywhere else. They start in a community. That community has exposure to maybe an antigen or a pathogen they didn't know before. It then enters the human body. Then the human body now is able to transmit it to other humans like that. So every pandemic starts as a small pathogen infection in an individual in a community. Okay? Meaning that if you're thinking of managing pandemics, where must you start? In the community. So you must build the community in such a way that it helps us to avoid the future pandemic. So it doesn't start by WHO. It doesn't start with the UN. It doesn't start with Amref. It doesn't start with Amref University. It starts with the community, meaning that as you study community systems, you must build them to ensure that if there's any new pathogen, it is recognized in time, it is responded to in time, and is controlled in time at the community. If you fail to do so, then you end up with a pandemic. So it doesn't matter what you did, it ended up leaving that community and becoming a global pandemic. So we must think of it that way. Then, of course, as we went along, a major event happened somewhere around 8th of December that science was working in the background, and that science delivered a vaccine. And the first person was vaccinated in the UK out of a clinical trial, because of course, when you're developing vaccines, you're also giving the vaccine to people as, voluntarily during the clinical trial. So those are not counted. The first person to receive this vaccine out of a clinical trial was Margaret Keenan from the UK, a grandmother, a very elderly lady. And that was now the start of the medical countermeasures. But before that, of course, we know that the world has already started with prevention. Those are the PPEs we wear. We are still wearing masks to date. We'll talk about that as we go along. But also that we had started to look at what medical components or products can help us to manage. And oxygen was top of mind. Oxygen was really critical in ensuring that we saved lives. So oxygen was one medical commodity. In fact, if you look at the history of oxygen, in many countries, it wasn't even regulated or classified as a medical commodity in many countries. And even in some countries did not exist in the essential drugs lists until COVID came, and it changed our view of oxygen completely. Now it's being regulated. Now there is major investments on oxygen. Then came dexamethasone, a simple steroid that, because people discovered that this condition, COVID-19, was about inflammation. It was an inflammatory disease and was creating a lot of inflammation in the lungs. And that inflammation is what was stopping the oxygen and then killing people. So again, dexamethasone came in to stop the inflammation. And then after that, there were other researches going on. There were other drugs, viral drugs. None of them really caught up. And then there was already a lot of misinformation. And you'll remember misinformation around ivermectin, misinformation around other commodities. But scientists were very firm that we were only going to follow science. So medical countermeasures started and followed. Please give me the next slide. So that was the timeline. 2 years later, 2 years on, the world has suffered drastically, and more than 6 million people have died. In Africa, about 249,000. People estimate that this number is underestimated or underrecorded. And the reason for this, to some of us, is because if you look at death recording, where you come from, I'm not sure that people who die at home are actually taken to the hospital to be recorded first. I don't know how many of us know that many of the people who die at home are police cases. You know that? They are police cases. They don't go to the hospital. So if you have somebody, there's something called dead on arrival. And dead on arrival means you've died and you're not, the hospital has nothing to do with trying to save your life. And therefore you're recorded in the mortuary, and then you're recorded in the police abstract. That gap or that divergence of recording of death is a major problem across the continent. And that's why, we must review these things, because then the people who are being announced, majority of them are the people who died in the hospital after being diagnosed with COVID and were in the hospital. People who dropped dead at home were taken to the police, and the police recorded them in the OB. So there is obviously a big gap between what is recorded here as deaths from COVID from what actually happened and the number of people who died. So we know they're underestimated. We also know that Africa had the lowest testing rate. So we know that the 11 million infections identified are again underestimated. But that's neither here nor there, because the aim of these numbers was to help us to identify the trends. But that's where we are. But you can also see that, the cases are dropping. If you look at daily new infections, the wave we had in January this year had the highest number of infections. It was the most rapid, and that was driven by the Omicron variant. But now you can see it's off the cliff. It's actually dropping rapidly. But something else I want you to note, other than the infections, is the deaths. That despite the fact that we had the biggest wave, if you look at globally, you're looking at, these charts show 7-day average. So you can actually take that to be the trend. And you can see that at some point, we had daily new infections, almost 4 million. Okay, but in the previous waves, if you look at the global graph, which is the first one, you have wave 1, wave 2, wave 3, and then wave 4. If you look at 1, 2, and 3, none of them crossed 1 million cases per day. You see that? But in Omicron, we went to 3.5 and above. But when you look at the death or the people who died, the highest number of deaths was actually around wave 2. And in wave 3, which had the highest number of cases, we had the lowest deaths. We'll talk about case fatality, in a minute. And that pattern is also the same in Africa. If you look at the side of Africa, you'll see the highest wave during Omicron, and then the lowest deaths recorded. So you start to think about the severity of the wave, because really you don't care about the number of people infected. What you care about is how many of those infected end up requiring admission, hospitalization, care, and may end up dying, because that's really where you should focus on. Because right now we don't count how many people get a common cold. We don't care because it doesn't kill. So the infection, being infected is not really the issue. Please give me the next slide. But also, please go back 1 minute. That the old age remains the largest risk factor for severe disease and death across from Wuhan up to now, where we are. Old age remains the biggest factor. Please go to the next slide. The thing I want to demonstrate here is to ask, why was COVID the most important event in Africa? And this is what I'm talking about. We have to also think, to challenge and also think a little more controversially, and start to ask ourselves, why was COVID the most important event in Africa? Yet, from the data that I've shown here, if you see the top causes of death in Africa are as listed, and those are actual numbers of people who die, number of deaths per year. And this is data for 2019. Sorry, I should have put an asterisk there. This is 2019. And you can see you have lower respiratory tract infections, those are pneumonias. You come down to diarrheal diseases as the one that kill the most people in Africa every year, HIV, AIDS. Then you have ischemic heart disease, stroke, malaria, tuberculosis. COVID is number 12 in terms of actual number of people. I've taken the 215,000 2 years and divided by 2. So I've not kind of looked at the dispersion. But just to demonstrate that if COVID is number 12 in terms of deaths, why was it the most significant event in Africa for the last 2 years? Yeah. If you have a view, you can raise your hand. If you're online, you can chat. Why was it the most significant event for the last 2 years? But when you look at, I've just taken one European, Italy, you can see that COVID was actually number 2 in terms of causes of death for the last 2 years. So it was really significant. It was the most disruptive new disease in some of these countries. And you can see, just looking at Italy, for you to compare, Africa, those numbers put them in perspective of 1 billion people. Say, assume it's 1 billion people. So any number you look at is death within 1 billion people. If you look at Italy, it's 6 million people. That's the population of Italy. So you can see up there, ischemic heart disease number 1, followed by COVID. So the first infectious disease that you see is actually number 10. That's the lower respiratory tract infection, which is number 10. Okay. So we have to think about these things. Was it the most significant event? People are still dying of malaria, they're dying of pneumonia in big numbers. But why was it a showstopper? Give me the next slide. And I'll be happy to hear your views and controversies around this. First, it was to protect lives, livelihoods everywhere. Remember, I talked about the international health regulation, that the international health regulations are binding. And therefore, you can't as a country decide, like Tanzania did, that this doesn't matter to us, therefore it doesn't matter to anybody. Because the control of a pandemic, of a pathogen that is of international concern is everyone's concern. It doesn't matter whether it affects you equally, proportionately. It is your responsibility as a country to ensure you maintain security for everybody. That's why the world agrees we are going to do a PCR test. We are going to do 1 or 2, 3. So number one is that it was an international responsibility for every country, whether you are having death or not. It's an internal responsibility. And that is why this thing here is Africa's strategy for managing COVID-19, which was developed by Africa CDC. Prevent transmission, which was critical, not only within community, not only within countries, but within regions and across the world. That was everyone's responsibility. Then, of course, number 2, prevent death wherever you should and you can. And then preventing social harm, which was more around ensuring that you reduce the harm to communities, because communities had to be disrupted. They had to wear masks, they had to stay at home, they couldn't go to work, there were curfews. So all those things are important. Give me the next slide. The next thing is to protect health systems, because whereas the numbers may look small over a period of 2 years or 1 year, they were happening within very small periods of time. The 125,000 I gave you is not, it's actually within maybe 2 or 3 peaks. So that 125,000, if you are to divide it across the year, you'll find that the 125,000 happened within 4 months on average, 4 or 5 months, because each peak is where you had the death. So if you actually picked the peak and extrapolated across the year, that number would not be 125,000. It will be millions of people, because you would take and assume this death would happen across the year. But now the death was happening in a very short time, which means that if the 125 is divided by 4, because we had, maybe you say it was 4 peaks, the 125,000, you'd end up with 30,000 people dying within a month. Now, if you are to multiply that 30,000 by 12, therefore you have 360,000 people dying, assuming that that peak was constant through the year, then it changes the dynamics completely. And therefore you have to think about, if the peak is 30,000 in 1 month, then it means that the health system could collapse, because it doesn't matter whether you'll have more deaths next month or the month after. Maybe the peak will have gone down, but you must protect the people when the peak is up. And if you do so, and when you do so, then you must protect the health system, because the health system could collapse and you'll be unable to take care of other diseases. Then you start now to see the difference, that there's a difference between a pandemic or an epidemic and outbreak management and an endemic disease, because the endemic disease delivers the death over a long period of time. But an epidemic delivers the sicknesses within a very short time. And that short time could collapse your health system, because you don't have enough nurses, you don't have enough clinical officers, enough lab technologies, enough beds to handle a surge. Doesn't matter that you will not have a surge next month, but if you have a surge this month, you have to protect it. And that, what I've shown in this chart is just to show you, when you talk about flattening the curve, then you see that your curve depends on how strong your health system is. If your health system is weak, then you must keep your curve low to protect the health system. If your health system is strong, then you can afford a much bigger curve, because you have enough people to take care of. So this is the reason why it was a significant event, because of protecting the world and also protecting your health systems wherever you are as you protect lives. Give me the next slide. And this is what I'm talking about here, that despite having the direct COVID-19 morbidity and mortality, sickness and death, you must also think around, what is the impact of that event on other diseases? If you do not protect your health system, then you could end up with people not being attended because they have diabetes, hypertension, mothers who need to deliver. So you then end up with a yellow curve, which is interruption of other conditions. So you must keep the COVID wave low to allow your health system to also provide care to other people. Give me the next slide. But of course, this comes with significant social and economic impact. I don't have to go to spend a lot of time on this slide, but basically to say that these measures that may look unimportant because COVID was number 12 on the list, and therefore you should have focused more on malaria and other things, these measures had a cost as well. And the cost was that people had mental health. People were hungry. There was increasing child marriage because schools were closed. There was a huge social unrest and political instability because people were refusing to obey curfew. That affected governments. There was a decline in GDP. So the gross domestic product and the economies declined. And then there was also a rise in teenage pregnancies, schools were closed, people didn't have money, so people are exchanging sex for money. Then you have unsafe abortions rising, you have maternal mortality, child mortality, mental health. So these were the compounded features of taking care of this pandemic to ensure we save lives, ensure we are part of the global health security, and ensure we save the health system. Give me the next slide. So where are we now? Next slide. So this is where we are. And is there an inflection? What I've done here is taken one of the graphs I showed you before. And if you feel sleepy, you can stand. I know it's an afternoon. And this is a long lecture. So feel free to stand, walk around, stand by the wall, because what matters is actually what you absorb, not where you sit. True, Francis? Good. So if you look at this graph, you will see that I'm reflecting on the July, the first real wave was July 2020. Then there was January 2021. Then there is July, this is Africa, 2021. And then there was January 2022. Which we just ended. That was the Omicron wave. And you can actually start to see a pattern that actually the waves were the equidistant. It's like July to January, January to July, July to January, in terms of the continental. The country ones were different, but you see the Africa one is accumulative of all the countries. But you can start to see the gaps between the waves. But if you now look at case fatality rate, meaning how many deaths were recorded divided by how many cases were identified. That's case fatality rate, which is different from case mortality. Case mortality rate is how many died and divided by total population. So here we are looking at, because we don't know, we want to relate to get a good view of how many people died out of the ones who are tested positive. The ones you didn't test positive don't care in this equation. So you're looking at case fatality. And if you look at case fatality, if you look at July, you will see it was 3%. That was the average, around 3%. Then it went up to about 3.2% in the January wave of 2021. Then when you come to July 2021, the case fatality dropped to 2.6. Now, there could be many explanations to this. First, there could be that people are developing immunity from the previous waves, okay? That could be one. Because when you talk about case fatality or the severity of disease and why a disease should be severe at a particular time, there are two conditions that can cause a disease to be severe. It could be the virus itself could be very severe, like the Ebola virus. There are also some diseases like encephalopathies that are so severe, you get it, you die. So it is the severity of the virus, but also the condition of the host. So those two factors, that you may have a very strong virus and a weak host immunity, or you may have a strong virus with a strong host immunity, or you may have a weak virus with a strong host immunity, or you may have a weak virus with a weak host immunity. If the output or the outcome of that situation will be different for each combination. So it could be that maybe the July virus could have been very strong, but then we had already started acquiring immunity. And where was that immunity coming from? People had been infected before, so they had developed some immunity, or people had been vaccinated, which is both acquired immunity. So you see the case fatality started to come down. But then you look at now the wave in January, and the case fatality has crashed to 1.1%. This is across the continent. So the case fatality now is very low. Despite a very high infection, the number of people dying out of the ones who are identified or are tested positive is much lower. It's actually a third of where it was before. And this is why I'm asking, is this an inflection? Because in real sense, when you have a disease, what do you worry about? Is it the infection or is it the severity after the infection? What do you worry about? Yeah? It's the severity after the infection, isn't it? So if the severity after the infection is close to 0, is that a disease that worries the public health system? Yeah? Hello? No, it doesn't, isn't it? Because, if you get infected, no one even cares because you just heal. It's like a common cold. Have you ever had a global health meeting on the common cold? Who has attended a global health meeting on the common cold? Yeah? But there are global health meetings on pneumonia, isn't it? There are global health meetings on COVID. There are global health meetings on rabies. There are global health meetings on B and HIV, because when you get infected, you could die and you want to save lives. But there's no global health meeting on common cold because the common cold doesn't kill. The case fatality is so low, it is insignificant. Therefore, we live with the disease, isn't it? So when COVID gets low in terms of its case fatality, what should we do? Should we then continue focusing on our resources, on monitoring how many people are infected? No, isn't it? Because if it's not causing death, then it's okay, you just leave it. And that's what we talk about, the endemic phase. That means that now it's with us, you leave it to continue, and you stop putting resources to its management. But if it is causing severe disease and death, then you put resources in its management. So the question is this Omicron wave an inflection that actually the case fatality rate is so low that we live with it? We don't have to bother too much about it. And the most important thing to do is now to invest in the health system, to make sure you vaccinate more people so that you reduce that case fatality rate below 1, and therefore you live with it. That's what we talk about the endemic phase. So the question I'm asking here is are we headed to an inflection towards an endemic phase? This is, of course, barring in a new variant that could change the case fatality. Because as I said, it's not only the host, which is you and me, it could also be the virus itself could change and then change these numbers. But of course, this case fatality is age dependent. It could be higher for older people. Just like flu, the case fatality for flu is higher for older people. Everywhere across the world, we don't wear masks for flu. We don't actually isolate people for flu. We just treat them, okay? Then it's dependent on the rate of vaccination. So this case fatality rate is different for people who are not vaccinated. It is higher for those who are not vaccinated. And it also depends on the medical care available to the person when they're infected. So if you're in a place without good medical care, then your case fatality will be higher. If you can't get oxygen, you get more people dying than should have died, okay? So that's the, give me the next slide. So then we come into this question of, so if vaccination is so important, then to reducing the COVID case fatality, then what's happening? What's the current COVID vaccination status? So the numbers here show the number of doses given per 100 individuals. So it's basically, you can say it's a percentage of people of doses that are given per individual in the country. So basically, if you have a country with 100 people, only 22 doses have been given in Africa. If you have a country with 100 people, 117 doses have been given in the rest of the world. So you can see that Africa is 5 times behind the rest of the world. That's basically what this chart demonstrates. Okay, are we together? Yeah. But why so? If vaccination is so important? So there are many things. One is obviously that we don't manufacture vaccines in Africa, and I will talk about that in a minute. We only manufacture 1% of all the vaccines that we consume in the continent. Okay? Please remember to stand if you feel sleepy. I'll keep giving that commercial announcement. Okay? It's a public service announcement, because I can see who is sleeping. So, you say that there's very little manufacturing in the continent. Only 1% of all vaccines, about 12 million. Africa consumes probably about 1.2 billion vaccines every year for childhood. You know, pneumonia vaccines, HPV, for measles, BCG. Only 1% are manufactured in the continent. Now, there are many other challenges. Number 2 is that even if Africa was to go and buy vaccines, we don't have enough money. We have a very low, small economy with very low ability to collect money from individuals, because many of them are border shoe shiners, you know, they are running informal businesses. You can't tax a farmer who grows carrots and goes to sell them in the market. So ability to tax is very low. That's what we call fiscal space. So economy is small and the ability to tax is very low. And then you have a fragmented market that even if you decide to invest in manufacturing vaccines in Uganda or in Madagascar, you are not sure that Central African Republic will buy them or Nigeria will buy them, because we have a very fragmented market, because every country in Africa is separate. You have 1 billion people in 55 different countries. In India, you have 1 billion people in one country. So it's a common market. In China, it's the same. In Africa, fragmented. So finally, it's also health service access disparities, that the vaccination access in a capital city in Africa is different from a rural area. So again, there are disparities, just like there will be disparities in access to antenatal care. If you're pregnant and you're in a rural county, you are likely to have more problems if you go into labor than if you're pregnant and you're in an urban center. That disparity does not only affect maternal health, does not only affect family planning access, it also affects vaccination, including COVID vaccination. So you must not assume that COVID vaccination is immune to health system inequities in the country. It is not. It is affected the same way other services are affected. So that's why I put this chart and said, if you look at the difference between, you know, the 22% of vaccinations up to 100%, the gap, we know that through a study by Africa CDC, that vaccine confidence in Africa is at 75%. And I've seen 2 studies. One says 75, the other 78. You can say it's around there. But then why is it that we have only vaccinated less than 20% of people? So people say it's hesitancy. Africans are hesitant. No, they are not. We went out to the university students here to do an outreach for vaccination, isn't it? We went to do a vaccination outreach, and we vaccinated 350 people in 6 hours in a place where we're vaccinating 30 people a day. So we know access is a big issue. So the first issue, plan for access. Then from 75 to 100, there is hesitancy, meaning that we should focus more on supply and access. But then I've added up there that these countries that have more doses than their actual ratio of their population is greed, because they started giving booster shots to people who had already been vaccinated before they could actually provide those vaccines to countries that did not have vaccines. Okay, give me the next slide. So let's stand now. We go through the future. Please stand up, all of us. Good, thank you. It's a hot afternoon and it's a difficult topic. So keep standing for the next few minutes. I'm just physically feeling jealous that all of you are sitting and I'm standing. So yeah. So give me the next slide. The future. How does the future look like? I realize that this lecture is largely attended by students of health systems, global health, and those kinds of things. So it's important for us to connect this conversation to the health systems. So health systems must be, into the future, a foundation for health, social, and economic security. And I think all of us have seen that. We have seen that from what I demonstrated, that you must protect the health system. To protect the health system, you must put curfew so that you reduce the force of transmission so that less people get sick, because then you separate people by making sure they're not together at night. You must isolate people. You must actually do lockdowns. You must close schools. You must remove people from going to church to protect the health system. But the flip side of that is that if you had enough money, you could build a health system that is so strong that doesn't need protection, doesn't need a curfew, because even if you have 1,000 people needing ICU, you have the ICUs, isn't it? Even if you have 10,000 people needing oxygen, you can give it to them. So the solution for health security and social and economic security is investing in the health system. So the health system is so resilient. I don't know how many of you have jumped on this thing. I don't know what it's called. Anne, what is this thing that kids jump on? What is it called? You know, I'm from an area that can't tell the difference between R and L. Huh? Trampoline. Is that what it's called? Can you imagine if you had a weak one? Okay? Then you give it a heavy person and they jump on it. What will happen? Okay? So you have two options. To stop heavy people from jumping on it is option one, correct? Or building such a strong trampoline that anyone can, then you make a choice. Now, the strong trampoline is a strong health system, so that even if there is a surge, you can still keep the market open, the economy open, because you don't worry that your trampoline will collapse. The alternative is what we did, saying no heavy people around here, meaning us stay at home because we don't want a heavy surge. Now you may sit down, then we continue. Now you're awake. So the health system is really the foundation for social, economic, and health security for the future. And how do you build this future health system? You must pay attention to universal health coverage, which, as Tedros like to say, is health security and UHC are two sides of the same coin. And that's what I've just demonstrated, that if you have a strong universal health coverage, meaning you have a strong health system that's accessible to all anywhere, then you have global health security. Because remember, we say pandemics start at community. So you need a strong health system at the community to identify the disease early, to treat it early before it becomes an outbreak, epidemic, and a pandemic. Meaning that for you to actually keep the world safe, you must start at the community. Make sure the health system there is equitable, it's accessible, that somebody who has pneumonia goes to the hospital early enough, and there is a lab to test the kind of pneumonia, and they're able to identify if it's a new virus or bacteria, and therefore ring fence it so it doesn't go to the rest of the world. Okay? So you must build a strong health system. But that strong health system is based on a strong primary healthcare system. And primary healthcare, for many of the students doing health systems and community health systems, is, or even practicing, is primary care, meaning when you say primary, we mean where people live, work, and play. That's what primary means. So when you build a system that is able to address to people's problems where people live, work, and play, and that is where most people need, then you're starting to build a good health system. Then it must have empowered people and communities, that people know what to do. During COVID, you saw we struggled to make people understand why they were wearing masks. We struggled to make people wash their hands because they didn't understand why we are telling them these things. But of course, it caught up. And I'm really happy with the investments in sanitation and water so far. The next thing is you must involve private sector. You must involve One Health, agriculture, forestry, because as we say, these viruses will come from the forest, from animals, and jump to human beings. So again, it must be multi-sectoral policy and action. Give me the next slide. And please let me know when I run out of time. Okay? But there's a problem because we don't have money. Okay, so I just want to reflect very quickly on this slide without paying too much attention to it. Just believe me, without looking at the numbers, that if you took Africa's economy and you taxed it the way Netherlands and Dubai tax theirs, meaning you collect the same amount of percentage of tax for every dollar people make, and then you actually allocate to health at 15%. Many of you who are in global health will know that we ask for 15% of the total country's budget to go to health. That's what we call the Abuja Declaration. If you did all that, meaning you collect enough tax from the economy at an average of 25%. So meaning if you earn 100 shillings, 25 is paid in tax. And actually that money is 15% of that is put in the economy. You then end up with only $64 per person for health. Whereas Dubai would end up with $4,000. Netherlands would end up with 1,800. And these are just hypothetical numbers. The real numbers are higher. For Netherlands, it's $4,000. For Dubai, it's actually about $5,000. For Sub-Saharan Africa, it's actually half of that. This 64 is hypothetical. So what can you do with that? So go to the next slide. So what you end up with, because you don't have enough money, people pay out of pocket, meaning that you don't have a good health system. Because if you have pneumonia, you have to think, which cow do I first sell for me to go to the hospital? And that's now the conversation of universal health coverage. If you're sick, if people are told you need surgery, what do? They say, we are going to come back. And they go debate with the family, they decide maybe what they need to do, they're going to do a fundraising to go to the hospital. So even if you have a disease outbreak, how many people in our continent will first wait until they find money to go to the hospital? How much assurance then do you get of health security if people who get a new disease and they don't know it's a new disease will stay at home until they find money to go to the hospital? It means by the time they find money, that disease will be with the whole community. So you cannot, without actually increasing financing, ensuring it's spent in the right places in primary healthcare for the right things, you can then not assure the world of global health security. And then that goes back to the international health regulations that have actually required certain investments for every country, but countries have been unable to do so because they don't have money. In which case then it brings a question. If the international health regulations require countries to invest in ensuring that they can identify diseases, but then those countries don't have money, whose responsibility is it to ensure that the investment to ensure global health security is done? You can't leave it to every country. It has to be a global responsibility because the security achieved is a global benefit. That's the debate we must think about. How do you actually invest in disease surveillance? Should it just be left to the country? If a country decides it doesn't care, then everyone is unsafe. So global disease surveillance must be something that we think about globally. And that is part of the conversation in the next, what we are calling the Pandemic Preparedness Treaty that's being discussed by WHO to ensure that the world has a common treaty that helps us to invest in disease surveillance in every country, because lack of disease surveillance in one country is a danger to all countries. Okay, I hope we are following that conversation. Give me the next slide. So of course I've talked about that, so give me the next slide. The result is poor coverage. So we talked about vaccines and we said we are not manufacturing. This is the manufacturing framework in Africa of vaccines, not COVID vaccines, general vaccines. You can see Tunis, that's Tunisia. We have some manufacturing in Egypt. We have some manufacturing in Morocco. We have some manufacturing in Algeria and Senegal. And some minimal, that's it actually. That's what we have. We have a lot of research in South Africa, but these are the countries that have actually been actively manufacturing. And of course, sorry, BioVac in South Africa. But you can see what they have been manufacturing. Some BCG for TB, yellow fever is probably the most prevalent, typhoid fever, influenza, polio. But all these manufacturing sites across the continent account for only 1% of our use in the continent. The rest of 99% are all imported. So even when COVID came, we did not have capacity to manufacture vaccines, not only for COVID, but even for other diseases. Okay? So the question now is, how do we move forward from this? We have started now, countries are already preparing themselves. We have seen countries, and there are many countries, maybe many of you had WHO recently announced 6 countries that are going to be given knowledge to manufacture what we call messenger RNA vaccines like Moderna and Pfizer. But these countries, even if they're given knowledge, they need the human resources and they need the capacity and manufacturing sites and the money to start the manufacturing. So there's also an opportunity there for the AMREF University and others to think about how do you support vaccine manufacturing in future, not only with creating biological experts who are able to manage the biologics that actually are needed, but even in terms of management, leadership of vaccine manufacturing, of health security. So there's an opportunity there. But South Africa has started now with J&J, and they're hoping to deliver 60 million doses this year and 70 million doses next year. So started. Give me the slide. But there's a bigger agenda of this, that we need to move from 1% of our consumption manufactured locally to 60% by 2040. That is part of what we are calling the commodity security in Africa. It is actually led by what we call the Partnership for Africa Vaccine Manufacturing, PAVM. And this is what we are looking to do to ensure that we go through many things. One, we have set the agenda. But secondly, we have to also do a market design. Because as I said earlier, it's not enough to manufacture vaccines in a country. You must know who will buy them. Remember, for Africa, the vaccines are not bought by country. They are given free by Gavi, because many countries can't afford to buy the vaccines they need for their population. So the Global Vaccine Alliance buys vaccines and delivers. So this COVAX you hear was actually delivering COVID vaccines to countries for free. So you must think about when you manufacture, who will they go to? If I tell you there's a big market for polio vaccines, and I give you $1 billion shillings to go manufacture polio vaccines, you must ask who will buy them, because they come to the countries for free. So even if you have the money to manufacture them, who will you sell them to? So that's market design, and that's something Africa has to think about. Secondly, you need to be able to have a common regulation, because even if you manufacture vaccines in Chad, and then you bring them to Burundi, what about if Burundi says we don't want your vaccines? So there needs to be a common regulatory environment across the continent. And now there is an agenda called the Africa Medicines Agency for Common Regulation, so that a vaccine or a commodity manufactured in one country can flow freely across the continent without needing every country to go through the regulatory again. Then you have to look at what money do you need? What technology do you have? And this is the role of research for institutions like yourselves, like AMREF University and others, to say that we are going to also involve ourselves in research and development for intellectual property. And that intellectual property doesn't have to be on manufacturing the entire vaccine. You could decide we are going to do research on only the packaging. You could decide you're doing research only on needles for vaccine administration. You could decide you're doing research on storage and cold chain. So when we think about vaccine manufacturing, let's get our minds off the very expensive process of ensuring you develop the RNA, that actually you go and capture the vaccines or the viruses. You could decide that our research is going to be focused on cold chain. And as AMREF University or as any other university, we are going to study how vaccines move from the factory to where they need to be administered. And we are going to advise on temperature differences. So research for vaccine manufacturing is not limited to intellectual property on the actual compound. So you have to look at the entire chain, and that's your contribution. So I want to call upon you as a university, as a researchers and the scholars, to actually look at vaccine manufacturing and vaccination supply and disaggregate it and say, for us as a health system university, we'll focus on cold chain. We'll focus on acceptance. We'll focus on use. We'll focus on administration. We'll focus on policy, for example. And I'll give an example here. Why is it that Africa does not allow pharmacists to inject? That pharmacists and pharmaceutical technologies are not allowed to provide an injectable. Only doctors and nurses. Do you know what that does? It removes an entire cadre of health workers from being part of administration. Is that an area of research? That's an area of research. To say which countries actually allow pharmacists to inject, which countries don't, and what is the impact on vaccine access. Zimbabwe started training 800 pharmacists during COVID to be allowed to inject, and they have to look at the policy. In the US and Europe, most people access vaccines from pharmacy outlets. They go to the supermarket, and in the supermarket, there are pharmacies. And in that pharmacy, they are allowed to vaccinate, and that's where people access their vaccination. Here, you cannot access any vaccine from a pharmacy because the policies don't allow. That's an area of research. Okay, so look at vaccination research widely, and that's the role of academic institutions. Give me the next slide. So we have efforts including WHO now sharing intellectual property. We have, as AMREF called out, for owners of intellectual property to give it out voluntarily to people, to manufacturers, so that we can expand vaccine manufacturing and access. But there are a lot of countries now, as shown on those charts, that are going to be, that are being asked to actually start to think about vaccine manufacturing. But are we going to be too fragmented? We need to think about who should manufacture what. If we all manufacture the same thing, then again, the market is destroyed. We must think through this and say, okay, you do mRNA, you focus on vials that are for packing, you focus on syringes, you focus on this commodity. Give me the next slide. So what should we do? And I think this is my last slide. We must ignore the hesitancy headlines in Africa. Because when we focus on the hesitancy, then we put money on the wrong things. We put money on radio, communication, TV, instead of putting the money on convenient access. I asked the question, why are we not reviewing the policy for pharmacists to inject? We need to review the policy, of course, guided by data. Say, what training do they need for them to be able to vaccinate? What capacity do they need in a pharmacy to store the vaccines? But that's an area to put money, because then it increases access. The next question to ask is, why is it that our facilities only open on Monday to Friday? What is stopping them from opening on Saturday? So there are many areas to focus on here, but when we focus on hesitancy, we then put the money in the wrong places. Oh, let's go and convince people. Let's hire an agency to tell people vaccination is important. People know vaccination is important, but if it's going to come when I'm selling vegetables and then close before I get home, then why should I bother? The next thing we must do is we must invest in the health system to accelerate UHC. As I've told you, you need to strengthen the trampoline, not limit the weight of the person. So how do we invest in the trampoline to ensure it's strong enough, whatever the weight of the person? So that then we build a health system that is able to take care of any surge. And that's UHC. And that also affects access to rural communities. The next point is we must invest in health commodity manufacturing in Africa. I've just talked about that. But we must think about commodity manufacturing, not for Africa, but for the world by Africa. If we think that we are going to build a manufacturing capacity to only manufacture for ourselves, we are then becoming too small-minded. We want to become a global manufacturing site that uses human resources from Africa to actually manufacture vaccines and commodities that can go everywhere in the world. The next point is, I talked about market design. I talked about the regulatory framework, so I don't have to go back. Then we must invest in industry-led, academia-driven research, meaning that universities like yourselves must look at research from the industry. The questions I'm asking about pharmacies, for example. But if you don't talk to the pharmacy fraternity, if you don't talk to the pharmacy council, if you don't talk to the pharmacists themselves and the people who own the retail shops, then you might actually do the wrong research. But when you involve the pharmacy population, then they are able to tell you, this is what we need to do, and we have the capacity to then offer vaccines, but we need 1, 2, 3. Then you do the research to support the policy change. So industry-led, academia-driven research. Finally, we must focus on preventing social harm. And this will be my last point, that we must follow science, that all the measures that we've talked about, curfew, lockdown, masks, PCR tests, have a cost to individuals. True? They have a cost to individuals. And that cost could be, this mask you're wearing, you bought it. How much is the cost of a mask, by the way? How much does one cost? Yeah? 20 shillings? 10, 20? So that is 10 cents of a dollar or 20 cents of a dollar. And if you have to do that every 2 days, because you don't reuse your mask, it's a substantive cost. And if you don't do that, you're going to be taken to jail in some countries now, like Kenya. They have actually created mandates that actually can take you to, has a fine of $200. So since it has a cost, you must only use it when the science says you use it. You can't leave it as an eternal tool. You use it when it's most relevant. So when you have positivity rates of 1 person in 300 people or 1 person in 200 people, then you must be able to review and say, I'm now removing the mandatory masks, okay? And I will bring them back if there's another danger of infection. Policy must be responsive. So we must review the mask mandates across the continent. Number 2, is that even when we talk about tests, we must ask ourselves, why is it that somebody must pay $100 every time they want to travel? And how many people who need to travel for medical reasons, business reasons, maybe somebody is moving from one country to another to go and buy wheat to sell, but they must spend $200 to and fro to do PCR tests, yet the data says that the infection rate is 0.3%. Okay? So we must form, and this is also areas of research for universities to say, universities have a role to actually do research and inquiries and surveys that guide policy. And say, now that we used masks, what is the effectiveness right now with this rate? What are other countries doing? Then you release a paper or policy brief that informs the country, informs the government. Because the governments have the tendency to wait and see what others do. But the role of academia and research institutions like yourselves is to get policy through data. So you can't just sit and say we are waiting for the government to make a decision. On what basis? So I'm challenging all of you to actually look at research differently, not just the one you do for passing your master's and passing your PhD. Continuous policy review and advice. Like, I actually think that we must review this PCR test completely. Until there is another danger, the cost to individuals is so much. The cost of masks is high, but also the cost of disposal of masks. Have you seen the environment? So policy must be responsive, but who is going to inform this policy change if it's not academia and scholars like yourselves? Finally, we must wear a gender lens, that in all these policies, we must think about the most affected, the most vulnerable. When we had the initial curfews, we had curfews that were blanket, 7 p.m. If you had labor at night, it's your problem. Because the policy did not wear a lens and say, if you have an emergency, if you're in labor, this is how you transition to care. So we must also currently and in the future always wear a gender lens in our policy making. And I think that's my last slide. Thank you very much. I hand over back to our moderator.
Thank you, Dr. I think that was a whole entire lesson on epidemiology and then another one on health systems. Thank you, Dr. I want to acknowledge our online audience, and as I do that, I want to ask, let's get a microphone ready so that we can be able to engage our audience in the auditorium. Prof. and Dr. This is an African conversation. We have people from Ethiopia joining us, from Tanzania, from Malawi, from the Netherlands, and South Sudan. Also allow me to acknowledge other universities that have joined us in this forum. I want to say thank you very much to Daystar University. We have some members of Daystar here, and we have others who have joined us online. I also want to acknowledge students from Strathmore University. We have their student leader here with us, and they have also joined us online. I also want to acknowledge the East Africa Students Union. We have some of their representatives who are joining us here today. We also have representatives of the South Sudanese Students Association, Council Kenya. We also have a guest from Ethiopia, from Arba Meki University, and we have student leaders from our neighbors, Riara University. So we really want to appreciate all of you who have joined us here in the auditorium and those of you who are online. Thank you very much. I want to request, I can see Bryson, you will help us in taking the microphone around. We'll be taking some questions, but before we do that, I want to take this back to Prof. From the list of questions, I would like you to highlight those that Dr. has not addressed. He has addressed quite many. And I want to start with the first one, Dr. There was a general feeling in Africa and in Kenya that we were responding to a mosquito with a hammer. So has that question been answered? Why was COVID-19 given so much attention? How many of you in the audience feel that question has been answered by Dr. Nobody. I think he actually gave a couple of points. Yeah. Number one, it was an international responsibility. We had to protect our health systems. We also had to think about the extended impact that was possible from COVID-19. And I think that has been settled, right? So, Prof.
Yeah, thank you. And thank you, our guest speaker, Dr. Githinji. I will paraphrase a number of questions which people have asked and try to, because there are many. We have over 30 questions. I think one question that people are asking on the issue of the vaccine, there are many questions on the side effects, but there is one on the issue of vaccine apartheid and you know, this COVID, how people have behaved previously. When the vaccine from India was brought to Africa and we started using it, in UK and other countries, they said they don't recognize it. So if you're vaccinated using that, they didn't recognize it. Now we are saying we are going to manufacture our vaccines in Africa. Will the world recognize these vaccines? And you remember the research from South Africa on Omicron. Initially, when South Africa said there's a new virus, people very quickly locked out or stopped travels from South Africa, Zimbabwe, Zambia, and so on, because they thought this is a dangerous virus from Africa. And you know, when we talk about vaccines repeatedly, and Africa lacking vaccines and other parts of the world getting the third dose, we've talked about vaccine apartheid, that Africans are not being seen as equal humans when it comes to COVID interventions. Africans are not being considered seriously when they talk about discoveries about COVID. In fact, before we knew that Omicron was not, the fatality rates were not that high, South Africa already said it, but the world kept saying, oh yeah, South Africa is saying this, but let's wait and see and do more research. It was not taken as a fact of research. So as we now start manufacturing our own vaccines, as the world says Kenya can manufacture and other countries in Africa, how sure are we that when we get those vaccines, we will be seen to have been vaccinated, whether it is for COVID or other things? How sure are we, as you said, that anybody else will buy the vaccines if we have them in bulk? Is it really something we want to do, given the position that we've been given in the world in global health?
Thanks, Prof. And I would say the answer is yes, absolutely. We have no option. And let me give a few examples. As I showed, Africa already manufactures yellow fever vaccines. We do get them from Dakar. And these vaccines and their certificates are globally recognized for travel. So many of us here have received the yellow fever vaccine. If you have to travel to India, South Africa, Tanzania, Uganda, they ask for yellow fever vaccine. And the yellow fever vaccine that you get is probably manufactured in Dakar, but that certificate is globally recognized. So the challenge we had with the recognition of the vaccines sometime last year, which we also complained about, was a challenge of certification rather than effectiveness. But the way it was framed, it was, we don't consider you vaccinated. But the real issue was, we haven't sat down with your government, looked at the design of the certificate, and therefore agreed that this certificate is acceptable. So it had nothing to do with the effectiveness of the vaccine. So it was a protocol and diplomatic failure. And that's why, after a bit of pressure, the government reversed that, because then they said, we are going to sit and agree on the certification. So it was a certification issue, not an effectiveness issue of the vaccine. The next thing we need to remember is that the most important thing I said here is that Africa should not be manufacturing for Africa. What that means is that Africa, whoever manufactures vaccines, must manufacture them to global manufacturing standards. And GMP, or global manufacturing standards, requires that there is exposure of whatever you're manufacturing to what we call stringent regulatory authorities. This is the reason why even the vaccines manufactured in Russia, for example, have not gotten a seal of approval from WHO. Russia is not in Africa. So the challenge is, are we going to manufacture vaccines or commodities that go through a global manufacturing practice that are globally recognized, that go through the same stringent regulatory authority as vaccines from other parts of the world? That's really the question. And that's why the point is, don't go and manufacture vaccines for Africa. Africa should add itself to the global manufacturing value chain, but manufacturing commodities for the world is the same reason why we actually import a lot of commodities into Africa come from India. They come from India. They don't come from Europe or America, but India has global manufacturing practices. So this must be the thought that we follow as we go towards this, Prof.
Okay, I'm sure there are questions in the audience. As we wait to see who has a question, there are others here online. And someone is asking, should Kenya be worried? Because elections are coming. There are many political rallies all over the place. Are we caught another wave? Will we be safe by August?
This challenge of elections and electioneering and campaigns in the middle of a pandemic has actually been a question throughout the pandemic in many countries. In fact, many countries had elections, the election cycle last year. I think other than one country that postponed the election, the rest of them actually went through the election in the middle of a pandemic. What that does is that it has a cost to the health system. It has a cost to lives. It has a cost to livelihoods. So I think it is the government to actually make a choice and say, what is the trade-off here? And a government that doesn't pay attention to saving lives and livelihoods is a government the citizens should worry about. I think, therefore, that's actually a decision of the citizens to say, if the government is behaving this way, then our right as the vote holder should be in this direction. So that's up to us, because governments can behave in whichever way they want, but everyone has a boss, and the government, the boss of government is you and I, is the people who hold the vote and the right to elect the next government. But then also we must counterbalance this. If the government decide to take a trade-off and say, we are going to continue the rallies because we cannot postpone an election, we have to continue, then the government then must say, then we are going to put an equivalent amount of money into the health system to ensure that we can save people's lives, and also in ensuring that everyone has access to a vaccine. So that should be the responsible thing for the government to do in an incident where they decide that they won't take the risk of continuing with electioneering.
Okay.
All right, Prof, let me just highlight a question here. We have Phyllis from the Ministry of Health who asked Daktari, how has investment in preventive health helped in handling the pandemic? And would you recommend more investment in the same area?
So we did say that the base of any good health system is primary healthcare. And then we said there are three things in the primary healthcare model that must be paid attention to. One is multi-stakeholder action and policy. That's what we are talking about. The Ministry of Education must be involved, One Health, veterinary, agriculture, private sector, all different stakeholders. Then we say the next one is empowered communities. And empowered communities mean educated communities that have decision-making power, that can make decisions about their governments, and that's what we've just been talking about from the question from Prof. The final point is actually primary care and public health functions. And what we've seen with the COVID-19 is that whereas primary care started in the beginning, we didn't have the commodities, we didn't have the PPEs for doctors, we didn't have reagents to test. Public health function rose very quickly. We had huge investments in water and sanitation. People were able to wash their hands wherever they were. And this has actually remained. I think one of the things which I must say is a silver lining to COVID is everywhere now you go, schools have hand washing stations, airports have hand washing stations, public places that did not have any water have hand washing stations. And I think this is an investment that is one big step for the health system, but also a learning that the public health functions must work alongside the primary care, because as we say, health is made at home and in the community. Hospitals and all these other facilities we have are garages for repair. So you must see doctors and nurses as mechanics.
Daktari, we cannot talk about COVID-19 and not talk about the mental impact that it had.
Yeah, as I said earlier, I talked about the social impact. It's actually I like to look at this as two pandemics. There was the biological pandemic of the direct impact by the virus, the disease and the death. That's the biological pandemic. But then there's a socio-economic pandemic, which is global again, which affected everybody. I think everyone can actually attest to the fact that they lost a form of income during this pandemic, whether it was them or their family, somebody close to them lost a source of income, that somebody, especially in Africa, contributed to the care of somebody who was in hospital because of COVID. And you know the social movement that happens when people are unwell, and the social movement when people lose lives, because then we have to also bury them. So everyone has had this impact. The final impact is mental health, that everyone has mental health impacted. In one, you lost an income. In another way, because you lost a loved one or somebody close to you. In another way, because your job was affected. In another way, because people living together had different impact. People lost jobs. There was domestic violence that was going on. There were actually closure of schools, and the closure of schools impacted parents and children equally. And even post the closure, when schools were opening, the impact of school fees, the payments people have to pay, the congested curriculums, fact that children were home doing nothing. So the mental health impact has been major, but I don't think we paid adequate attention to it. And I think that the impact of the mental health illness and the mental health impact will be seen actually many years after COVID-19. We have seen suicide rates rise. We've seen gender-based violence rise. And what is going to be the impact of this a few years after the pandemic? So this is something we must pay attention to. And we haven't done enough investments in the health system. And those investments are not necessarily medical commodities investments. They could be communities in investments in community resilience. People were out of churches because churches were closed, and churches or places of worship were actually mental health support for many people. So we must think about how to build this community-driven mental health, and mental health being machinery that takes care of people where they are at any time without relying on the medical and health infrastructure.
Prof, do you have a question as we wait for the audience?
I think the audience now has questions. There are two. We can start with Prof there, and then the gentleman. Go ahead.
I don't think that mic is working, is it? You could, we can hear, but there's an audience online, so they would like to hear you. So if you could use this one, actually. Yeah.
Okay, thank you. Just an observation that at the height of the pandemic, when we saw relatively very high mortality and case fatality rates in developed countries like Italy, we held our breath in fear of what was going to happen in our slums, where basically the basic interventions of even washing, hand washing, water is not available. And if there is any water, it will be prioritized for something else other than hand washing. But eventually, the mortalities and case fatality rates that were observed appeared relatively much lower than had been feared, given the circumstances and conditions in such places. I don't know whether you have any comments on this and the reasons.
Thank you, Prof. And I'll give you my opinion, which people have given all sorts of things, talked about the concentration of melanin and all these things. But I actually think they're unfounded. But scientists have the freedom to think and to hypothesize. So I'll give my own right to hypothesize. And the first thing is what I said, that the case fatality rate is age dependent largely, okay? Now, if you look at countries like Italy, the average number or the percentage of people who are above 60 years is about 25%. So they have a huge population. So if you look at 50 million, 60 million people population, and you say a quarter of that is over 60, you're talking about 15 million people or more, okay? So if you actually then look at that 15 million people and you say that the case fatality for elderly people is 17% or 20%, you're doing 10%, 20% in a population of 15 million people, because that's where the case fatality is when you go up. Even if you look at numbers from Africa, you'll see that most of the people who died, 60 to 70% of the people who died in every other countries were above 50 years. So if you add that age dependency to the case fatality, then you can tell the difference. Africa has only 3% of people above 65 years, whereas a country like Italy is about 35, US about 17%. So age is a big factor. Number two is, you talked about slums. The slums in Africa are mostly young people because of rural-urban migration. So therefore, you add the age factor to the composition, the demographic composition, because urbanization is a relatively new phenomenon in the continent, okay? And therefore, it is the young who are migrating. So I would like to look at age-dependent case fatality in rural areas, which is also a research interest to universities to say, can we actually go and say, can look at case fatality in the rural areas versus urban areas? That's an area of interest for research, because I actually think that majority of the older people are actually in the rural areas, okay, rather than in the slum areas. So it's age. The final point I would say is that the other risk factor was hypertension and diabetes. These are lifestyle-related diseases. They're age-related, they're lifestyle-related. It is the cardiovascular complex. If you look at the people who live in the slums, they don't farm. They actually leave every morning and walk 5 kilometers every day to look for work and walk 5 kilometers back after work. Those people are likely to have a much lower incidence of lifestyle diseases than people who are sedentary. So I think it's a complex of reasons, but age is definitely the most important.
Okay, thank you. I'll first introduce myself. My name is Arizon Ochieng. I'm the Secretary for Health and Research at the East African Students' Union. Now my question will be two, first from a national perspective and the other one from a global perspective. So I'll start from a national perspective. Well, I think it should be 2 months ago, we had the NHIF Act of 2020 that one of these mandates that every Kenyan citizen should actually get an NHIF. And as we know, for the scheme of NHIF, those who are employed will be able to pay, will be paying around 500 shillings per month, and the employed will be paid now. What I'm looking at is we're trying to figure out now how we can get everyone insured, which is a really great move. But one of the issues that comes up is a big percentage of the Kenyan economy is actually informal. So you get a big percentage, you'll be paying 500. So that brings another question, how the sustainability. Now, according to the Abuja Declaration, counties are supposed to spend roughly around 15% on health. And Kenya's the 2019-2020 financially have only spent around 9 to 10% in both county and national health. So you look at the spending and what we're trying to commit ourselves into, and you look at the sustainability, which also brings another issue. When the Affordable Care Act, popularly known as Obamacare, was implemented in the US in the year 2010, we saw that many people could now access care. It put a pressure on the previously existing nursing shortage in the United States. Is our health system ready enough to accept now this influx of the number of patients who will be seeking care because they're now insured? That's the first question. The second question now is on compassion fatigue and secondary trauma. We realize that the healthcare workers across the globe, compassion fatigue, secondary trauma was everywhere because no one was prepared for this pandemic. Looking at our country, the KMA, KMPDU, and came together and established a call center where healthcare workers will actually call for probably counseling. Do you think there are strategies that can be adapted so that in a future pandemic, so that this, the extent of compassion fatigue and secondary trauma among healthcare workers is not to the extent that it was as experienced in the COVID pandemic? Thank you.
Thank you very much. So I will talk about, I'll start off with the NHIF one, then I'll talk about this compassion fatigue. Now, the challenge of health financing is first and foremost the ability to collect taxes. Because health is a social welfare issue, and health must be provided for by public finances. That's what works best. When you tell people to pay out of pocket, then you end up with people getting bankrupt, people having to sell their resources. So people live in fear, and therefore they can't build wealth. And therefore you can't build a country on people who can't build wealth or people who are sick. And therefore you must look at how do you actually collect the taxes that are adequate to provide for health services. Now the 15% Abuja declaration is 15% of the country's budget. So if a country is spending $100 in total, $15 should go to health. That has been the argument. Now, the other argument is that that 15% should be close to 5% of the country's GDP. Now, when you actually look at that 15%, and then you look at the competing priorities that also contribute to health. Education contributes to health in a big way. People educated and empowered are actually likely to be more healthy than people who are not, okay? Women who are educated, and there are studies on this, women who are educated are more likely to adopt family planning methods and to plan their families than women who are not. So when you talk to the government, they say, we are contributing to health by putting 30% of our budget on education and putting 7 to 8% on health because they are two complementary services. The next thing is to ask yourself about investments in water and sanitation. So the question many of us now asking ourselves is, when you count the 15%, should you count only the money that goes to the Ministry of Health, or should you also count the other complementary services where money is spent? So that's a question in health financing generally. But now when you ask about NHIF, NHIF is an example, and many of the people listening here from across the continent. The question NHIF should present to us, just like NHIF, the NHS in South Africa, the NHS in Nigeria, the ongoing NHIF conversation in Uganda is, what ways should we use to collect money to pool for healthcare? Many countries have said, we collect tax, then we pay for it. It's never adequate, because I talked about the low fiscal space. But there are a lot of people who can contribute, but they are outside the tax budget bracket because they're doing informal work, as you said. So what NHIF is trying to achieve is, how do we make sure that people who are actually earning but are not in the formal employment can contribute by ensuring that it's mandatory? So if you own a shop and you need to renew your license, you must first show your NHIF card. But if you don't own a shop, then you have nothing to show. You're not seeking a license because you're poor. Then the government pays for you. Says, as long as you don't have any business activity, the government will pay for you. If you have business activity, you will not be licensed to carry it out unless you have shown NHIF. You get, so this is where we are going to. But then you come to the final question about the capacity of the health system. The capacity of the health system right now is actually muted by the ability to absorb. So we have many nurses. We are training nurses here. Many of them are jobless. So they're actually there. And this is why when you talk about health worker shortage, it's artificial. It is because of the inability of the health system to absorb more health workers. So if you capacitate NHIF with money that then flows back to the health facilities, then the health facilities will be able to employ the health workers they need as demand grows, because there is autonomy of the finances and the finances are flowing back. So that's the assumption here. But then it must be accompanied by some regulatory changes to allow health facilities to receive money directly, to create accounts, what is called Facility Improvement Fund, which was removed in the current constitution. So there are a lot of changes that are happening to enable NHIF money to actually enable a stronger health system.
Yeah, I think we are almost moving towards the end. So maybe we should allow 2 more questions from the audience and maybe one from online. We will have other sessions talking about, because I think like health financing, we need a deep discussion. So we will definitely create opportunities for that. So we can continue with COVID. Yes. Go ahead.
Okay, thank you. My name is Donald Magomere, a very concerned citizen. First of all, let me thank you for the presentation. It's very comprehensive, and since it's a public lecture, I don't know whether some of us will have an opportunity to get the slides of the presentation.
Yes.
Okay, my first question is, Doc, you talked about a problem because we don't have money. And at the same time, we have seen from a Pan-African perspective, we've seen COVID funds being it's kind of being squandered in a way. We've seen it in Kenya, we've seen it in South Africa, we've seen it in Ghana. And in your presentation, you mentioned that we don't have money, but look at the little money that we have received even from donors. I mean, it has not been spent well. I mean, where do we put this in terms of the COVID funds that we receive from donations and other sorts of aids? Then the second one is the vaccine hesitancy. You've spoken about kind of a way you've disregarded communication, and you've said that other sectors need to be funded. And when you look at the height of hesitancy, it was happening in the rural sectors. And the only way that rural sectors can get to hear about the vaccine, it's all about communication, especially radio. So where do you place communication at the midst of all this hesitancy? Thank you.
Good question. So let me start off with the first one, that COVID billionaires were not limited to Africa. COVID billionaires were global. Actually, the largest COVID billionaires were in Europe. That's fact. But the ones that we know are the ones around us. So there was general misuse of funds across the world, in South Africa, in the UK, in the US. In fact, I heard about 115 billion pounds scandal in the UK on COVID PPEs. Some of them that were bought have never even been used because they were substandard. So it is a general decadence of trust across the world. It's not about Africa. The question is, what can we do as Africans to protect this from happening in future? And it is about active citizenship. I'd want to see citizens actually collecting information and taking some of these people to court. And taking them to court and saying, you know, you benefited from public funds, we are going to take you to court. And that means that we need strong civil society that actually is able to find the information and finance the investigations so that public people themselves can take individuals to court. So I think the solution needs to be about citizenship and citizen activism, because every government in the world will try to misuse public funds. That's my response to your first question. So citizen activism, because it's not an African problem, it's actually a global problem. The question on communication is a very important one, because the point I'm trying to make here is not that communication is not important. It is that communication is not the only thing that government need to do. So the first thing we need to do is ask ourselves, why do we have low absorption? We have to follow data. And that's why I'm calling about academia and those people to do research and go out and actually we have case studies that show that people in an area that was providing vaccines have not accessed the vaccines, but when you change the approach, they access the vaccines. Without communication, you just go there and you're available. So the question is, how much is hesitancy? How much is convenience? How much is availability? How much is compassionate care in the place where you're getting? And that needs surveys and data. And that's why we're talking to academia. So right now, the data that's available from Africa CDC on vaccine confidence says 75% of people have confidence to take the vaccine. But yet we have only 20 or less percentage. So what is the gap? In our case studies, it shows the gap could actually be access, convenient access. And I give an example of this outreach. But also, if you look at data from South Africa, I've looked at it, data from Tanzania, Uganda, and Kenya, you will find that rural counties have the lowest vaccination rate, while urban counties have more than 50% vaccination rates. But when you look, you don't have a gap in hesitancy. The gap is actually access. Just the same way you have a gap in access of DPT vaccines, a gap in access to antenatal care. So it's actually, there's hesitancy, but the bigger gap is convenient access. So they're both important. But now if we don't understand this gap, which is not visible, of the inconvenient access, then we address the one that's visible and ignore the one that's not visible. That's the point I was trying to make. And I haven't seen good gender balance in the question, so I'll be happy to see a question from a woman.
Thank you, Dr. My name is Marco Laboso. I'm the student president at Daystar University. First, I'd like to laud you because that was quite a breathtaking public lecture. It has enlightened us and actually empowered us. Now, as a young person and as a Kenyan and as an African, my question is COVID-19 here to stay? If you look at the statistics, you'll find that in Firstly, in Kenya, the numbers of people who've been fully vaccinated are just above 7.6 million. You look at Africa, and it's closely above 397 million, according to the World Health Organization. Yet we talk about having 1.4 billion Africans in this continent. So as a young person, is COVID-19 here to stay?
COVID-19 and the virus that causes COVID-19 disease are here to stay. The question that we discuss is, are they going to stay as a disruptive pandemic, or are they going to stay as an endemic disease? Meaning that they will stay, but the people who are unvaccinated will bear the brunt of the pandemic and the severe disease, which we don't want. So the answer to the first question is yes, it's not going anywhere. The next thing to consider is that what will the endemic phase look like? Since it's not going anywhere, what will the endemic phase look like? The endemic phase will mean that we need to make sure that as many people are vaccinated as possible so that we change the host immunity, and therefore, even if they're infected, they don't get severe disease. So the most important factor moving forward is actually vaccination. And that's why we are addressing the issue of communication, closing the gap to access of care, because we know urban centers have a much higher vaccination rate than rural centers. It's actually an access issue. So how do we close that so that in the endemic phase, everyone has good host immunity to avoid them from getting severe disease? Because infection from coronavirus will be like next thing. It will be almost everyone will be finding that the coronavirus is everywhere they get infected, but can they protect themselves against severe disease? Yeah.
Thank you, Prof. A lady, we are going to give a final question to a lady in the audience. Yes.
Good afternoon and thank you. So my question would be, what is your take on, let's say now we are trying to develop more or less a herd immunity. What is your take on us still having masks on? Because I feel like at the rate at which you are heading to, is it really significant for us to keep on having the masks? We're still having the vaccinations and all that. Does it really have a big impact on us still having the masks on and not having them on?
Yeah, so this is the question I handled. I tried to tackle at the end. And I said that if you follow science, the mask is a physical barrier to getting the virus. Now, it is best served, or it is best effective when the possibility of you meeting the virus is high. Okay, so when you have positivity rates above a certain level, then you should wear a mask, because then it is most likely you'll meet somebody who has the virus. When the positivity rate is low, like now 0.3, 0.5% in most countries, then the mask doesn't serve a significant purpose. It doesn't mean that it doesn't stop the virus, it still do, but the chance of it helping you because you are less likely to meet somebody is much lower, which then means you must weigh the benefit versus risk. It doesn't mean that the risk is absent. It is to say, what is the benefit of a mask when the chance of meeting somebody with COVID is so low? Then you say the benefit is so minimal that the cost you're paying for it should not be paid for, and then you remove the mask. That doesn't mean that it is an eternal decision. If now the positivity starts rising, you must tell people now the danger is high, please wear your mask. So you have to follow science and decide. So right now I would say the mask should be removed, except in indoor settings where there is a high likelihood that you could get infected. But mandatory mask in the general public should be removed. That's my position. And that's my position publicly. And that should also reflect on the PCR tests, which are expensive. The question is, do they serve any purpose now? Can we shift to antigen tests? We should shift to antigen tests until the positivity goes up or there's a risk of a new variant, then we shift back to PCR. But that is a call that needs to be made by the policymakers, guided by data and information from academia and researchers. I think that should be the last.
Yes, Amabor seems to have a burning question.
Okay.
Thank you, Madam President, Dr. Gitai, Prof, and everyone. My question is on universal health coverage and the mechanism of financing it. When you look at Kenya, NHIF coverage, I can see we are standing at 15 point something percent, considering the years it was established since 1966 or 60 something there. Compare that data with the Rwanda, which has 85% of their population covered for the national health insurance, which they call it community health-based insurance. That scheme was established in 2004, which means comparing with Kenya, there is a big difference. When I read around NHIF, I found so many loopholes emanating from transparency, because you are in a position to pay. Like today, many Kenyans, like for example, myself, I use an NHIF card, but I don't know what is in it. I don't actually know. The money I pay, I don't see it. I don't know what I have used. I don't know what is there. So what do you say about transparency when it comes to use of NHIF card? Second to it, the reliability of this card. For example, today, personally, I have not been around here. I came yesterday and I will leave this evening. I'm outside Nairobi. Let's say, God forbid, I get sick where I am. And the hospital that I chose when I was registering is in Kenya, is in Nairobi. It is not in Kajiado County. I won't be able to access services because the health facility I chose is in Nairobi. So how reliable is that? And what should the health policymakers in Kenya do around that, such that the card can be made reliable to make sure that it covers actually what is needed by the citizens? The citizens are getting insured, yeah, but the services that they are getting are poor. Recently, I have a friend who is insured. He has been paying since 2013. There are these private impaneled hospitals who actually used NHIF. But when you go there, your NHIF card can only afford the consultation. The rest is from your pocket. So the question is, what exactly are we spending money on? And what should be done such that this scheme can be transformed to actually achieve the universal health coverage that Kenya is trying to reach? Thank you.
Yeah, I'm thinking the lady can also just give her question. That will be the last, then they can all be answered together. Oh, is it okay? Oh. Sanitizing, okay. Go ahead.
Good evening, everyone. And my name is Vivian. And mine is just a concern about the registration for COVID-19 vaccination. I think not so many people, we can say that have IDs or they have registered for identification, like young teenagers who have just left school and they're joining campuses. They've not yet been issued with the ID card. So this is hindering them from getting the important vaccine just because they don't have an ID. What is your opinion or your view on this? Plus also, maybe we have immigrants from other countries in this country, and they cannot access this service because they do not have probably maybe a passport. Maybe they just came via, they don't have the passport, they don't have the ID. What is your view on this? And is this hindering many people in Kenya from getting the vaccine?
Okay, thank you. So let me start off with NHIF, then I answer that, and then we can close. Number one is that Rwanda started the NHI, the health insurance scheme many years ago. Then in 2008, they made it mandatory. Making it mandatory meant that every chief needed to know how many people in their vicinity are registered and had to make sure there was 100% registration, otherwise they lose their job. It was mandatory. So they use a mandatory approach and they use a community engagement approach. Kenya just ended mandatory in the current bill. So before that, it was only mandatory for the employed people. So you can actually see the gap in registration. So we're hoping that Kenya now will accelerate and reach where Rwanda is. The second point is to say that the service package is determined by affordability. If you don't have money, then you offer a small package. NHIF currently pays about $500 million every year on health. The problem has been the balance between how much goes to the public sector, how much goes to the private sector. A lot of the money goes to the private sector and very little to the public sector. The final point is because of that, there is fraud because private sector is trying to defraud NHIF because they're trying to make money. There are institutions in this country that are actually created to make money from NHIF. So now the NHIF has moved to biometric, meaning that you cannot charge for somebody who didn't actually access service. Secondly, they are becoming more data transparent through this biometric, and you can access your service package online. The problem that you're raising on outpatient is a very difficult problem to monitor, and that one can be addressed in a health financing session, as Prof said. There are a lot of things, but this bill, the current bill, review it, and you will see the sweeping changes is made that are going to make NHIF more accessible and more available for Kenyan people. And I hope that other countries in Africa can follow a similar path. And as AMREF, we are actually assisting countries to move towards their journey towards UHC through something we're calling a UHC delivery lab. And we're happy to engage with governments across the continent. The question on IDs was realized a long time ago. It is one of the challenges we talked about, which are access. It has nothing to do with hesitancy. That's exactly the point I'm trying to make. That when you have system glitches, then you say people are hesitant. They're not. If I come to a vaccination center and I'm told you need an ID, I disappear. That's it. I'll never come back because I don't have that time to keep coming back. But now that was actually overcome. If you go to the system, there is all manner of registration formats. You can register as somebody who is in the country, who is, even if you don't have an ID. And there's now a tab to create a unique identifier that you don't have an ID, we just raise for you and you create a unique identifier which you're given, and that becomes your reference point. So you don't need an ID, and you can use your birth certificate, or if you don't have any of them, you use a unique identifier. But that took time to bring in, and therefore a lot of people miss the opportunity to get vaccinated. These are the system access glitches and convenient access that I'm talking about that needs to be resolved before saying people are hesitant. So I hope I've answered your question. And thank you very much to all of you. Thank you.
Thank you. I think it is very clear, Prof. and Dr. We might need to do another session which we shall handle health financing and then tie it with UHC in Africa, because we are looking at the African perspective beyond Kenya. Prof, would you like to give some remarks?
So mine is this is the work of the student community. And so thank you very much for creating an opportunity for all of us to converse around these very important topics. And I know we will be planning more. Maybe the next one will be on health financing, seemingly, but we will be happy to attend again and converse. Thank you very much, and back to you.
Thank you. Let me say a very big thank you, Dr. Gidenji. We are proud to be associated with you as AMREF International University. It is an honor that you could take time off your schedule to be here, engage with many students online and others in the auditorium. To the students who are here and the ones who are online, we would like to do this more often. AMREF International University is student-oriented. So we would want to know what topics would you like us to discuss in future. Email us. We sent you an invite through email. Give us feedback on today's session. Let us know what you would like us to talk about in future, how you would like us to engage. It is all about the students. I want to thank the head of departments for their support. I want to thank the Dean of Students in absentia. I want to thank our VC for his support this entire period, and to everyone who joined us. Thank you very much.
Thank you very much.
And I see some refreshments. I don't know, Betty, whether you have whatever you want to say. Thank you.